Hi, everybody. Welcome to Texas Primary Care Consortium's monthly Monday Primary Care Talks. My name is Nishi Singhal. I'm the program officer with the consortium. These monthly Monday Primary Care Talks, they are dedicated to interviewing guest speakers from across Texas, covering a wide range of primary care topics. Each month, we are committed to bringing you informative episodes as your go-to resource on all things primary care. And so today I'm very excited to introduce Laurie Vanhoose. She is the principal at the Treaty Oak Strategies organization. She provides effective strategic counsel on healthcare policy. Laurie helps her clients navigate the legislature, health and human services, managed care, provider relations, pharmacy and pharmacy benefit managers, and the Medicaid and CHIP program. Prior to finding her current organization, Lori was a director of policy and government programs at the Texas Association of Health Plans, where she worked directly with Texas's Medicaid managed care health plans to ensure a strong and efficient Medicaid program. Lori has also served as a director of Medicaid and CHIP policy at the Texas Health and Human Services Commission, where she directed policy and clinical staff in the design, development, and implementation of Medicaid medical and program policies. She is a wealth of knowledge, and I'm very, very excited for all of us to hear more from her. Let's go to the show. Thank you so much, Lori, for joining us today. We are really excited to learn more about your work. I know I especially, I'm newer to your work, so I'm really looking forward to today's interview. And so with that, if you really could tell us a little bit more about yourself, but also really how does your work impact our primary care system here in Texas?
Yeah, well, thank you for the opportunity. So my name is Laurie Vanhoose, and I have a lobbying consulting firm called Treaty Oak Strategies. We focus mostly in the Medicaid and CHIP Medicare world. Have some experience working in with pharmacy and commercial healthcare, but my background really focuses on Medicaid and CHIP. I was previously with the Health and Human Services Commission and oversaw the Medicaid CHIP policy division, where we designed a lot of the programs and implemented a lot of the legislative direction and federal changes to our Medicaid program here in Texas. And then after working for the state, I also worked with the Texas Association of Health Plans. So I got the opportunity of working with the state and developing Medicaid policy, and then working with the health plans that administer the Medicaid program to ensure better access and higher quality of care. So that's kind of been my goal. And then before all of that, I worked in the advocacy world. I worked for Disability Rights Texas, then I worked with AARP, and I moved down here from DC after lobbying for the National Disability Rights Network in DC. So it's been fun because I've been able to see the member side, the advocacy side, and work on that side, work at the agency. And it's so hard working at the agency and the work that they have to do to implement programs successfully. It takes a lot. And it gave me the opportunity to really understand the provider perspective, the member perspective, and then also the state agency perspective. And then working with the health plans is a different perspective. So kind of have this 360 view of what all has been happening in the healthcare world over the last 20 years, especially as it relates to Medicaid and CHIP. So because of that work in the background, I've been doing a lot of work with several different entities, one of which is the Physical Health Foundation. So I've done a lot of work with them over the past several years. When I was with the Texas Association of Health Plans, we worked together to develop the Medicaid Managed Care Non-Medical Drivers of Health Learning Collaborative. And we are just now in our fifth year. So I think that's pretty impressive for a learning collaborative to go into 5 years and to continue the conversation. It still be invigorating and innovative and interesting in our fifth year. And what we're doing, that learning collaborative really is bringing together payers, providers, the Health and Human Service Commission, and some of the foundation. The Michael and Susan Dell Foundation also helps support that learning collaborative to learn about what's going on in the space around non-medical drivers of health and who is doing what, who is being successful. And I would be remiss if I didn't say we're also bringing in the community-based organizations into that conversation. How can we bring payers, providers, community-based organizations together to improve access to healthcare, improve the quality of healthcare? And what interventions are working? Where do we need more support from the agency, the legislature, Where are those pitfalls and barriers, and how can we continue to move whole person health along the continuum? So that's one project we've been working on a lot that I think has a major impact on primary care. If we can ensure a Medicaid member has the transportation they need to get to a doctor's visit, and they're going to go in and get that primary care visit and not end up in the emergency room later. Kind of spinning off of that work also is a lot of work around alternative payment models. The healthcare world is moving towards paying for quality. It's hard. It's not easy. It sounds like, APMs are going to solve the world, alternative payment models and value-based contracting. They have a huge capability of moving the needle and improving healthcare, but they're difficult and they take a lot of work. So I've been working with some providers, various providers, federally qualified health centers, for example, we feel like a great space to really innovate, because there's so much primary care going on, and they are in that space, and they have the ability to refer and screen and identify non-medical drivers of health needs, and also identify behavioral health needs. Be more comprehensive. The FQHCs have a very comprehensive view and have the ability to provide comprehensive care. So working with them on how can we innovate care through paying for quality. But then also we're seeing pay for quality and alternative payment models move into other provider groups. So home health agencies, DME companies. There's a lot of space that we haven't really moved into that has a major impact on the overall quality of care that a member receives. So you may have great primary care, but if that is a member is an individual that has a significant medically complex need, but they don't have the right DME to stay healthy, they're not gonna, it doesn't matter what we're doing if we're not ensuring the full comprehensive care. So working a lot around paying for quality with providers and payers, and even HHSC, on how do we really move the needle on this? Because it's hard. It's hard. They're administratively complex. They take a level of sophistication. They require data sharing, but it's so important that we continue to work together to move in that direction. And then I'd say the other big thing that I've been working on that's really exciting and I feel is innovative in Texas is last session, House Bill 1575 passed the legislature. And what that will do is it'll allow community health workers and doulas to serve as case managers for pregnant women in the Medicaid program. And, what we've experienced and what we've seen, the maternal mortality rates, yes, but when you talk with and have experiences working with women that are in the Medicaid program, what you hear from them is education is a huge issue for them. They don't know where and how to access care. They're relying on their social networks and their peers who've gone through this to understand where and what to do. And they face a lot of barriers. Their coverage is a shorter period of time than other Medicaid members. They face after the delivery employment, transportation, housing, in addition to losing healthcare coverage after delivery. So having a community health worker or a doula hold their hand and help them navigate the healthcare system, not only while they're pregnant, but after they transition off of Medicaid to find other resources, I think is really important to ensure we have healthier moms and healthier babies in the future. And then what we're seeing here in Texas is the development of some new hubs that are coming up that employ community health workers. So there's in 4 areas of the state, these hubs are being created. So I'm helping support the development of these hubs where you could refer individuals that have healthcare needs, and then those community health workers can navigate everything from how do I access healthcare coverage to how do I find a primary care doctor to how do I find a food resource if I have a food insecurity. So kind of doing a lot of work around paying for quality, but also looking at whole person health.
That's amazing. I love how you said that you've worked at, kind of different stakeholder shoes, right? So there are all these people around the table and you've kind of sat in their chairs, so to speak, sorry. And it's so fascinating to me because my background is in public health, and so my context is always how can we put ourselves in the context of others, essentially, right? Because you realize even if maybe on the surface you seem like competitors, there really are shared interests there that exist for everybody, and shared goals. And so I'm curious if only you can speak about it, what are some of the takeaways or what are some of the learnings, I guess, from this 5-year learning collaborative that you guys have facilitated so far?
Yeah, I think, we've learned a lot. And I think what we've learned is Well, exactly what you just said. Bringing everyone to the table is so important, and we've just not done that to the extent we possibly can to ensure, better access and better communication and better data sharing. So the collaborative has been kind of the first step of bringing even like a community-based organization to the table. They don't know, what we've learned, we've been working with some of the food banks is that the food banks don't understand everything that a Medicaid health plan is supposed to be doing or is in charge of doing, and then vice versa. The health plans think of a food bank as just someone to refer a member to for maybe one or two like canned meals or something. But then you find out that the food banks are doing employment assistance, and they're doing assistance with helping members and individuals apply for other types of benefits. They're doing a great amount of things. And so it's been nice bringing together different entities who've always wanted to work together and kind of work together at arm's length and letting them better understand where the linkages are and what they could possibly do together. And then I think the biggest barrier we faced is how do you then pay for that under the Medicaid? Because Medicaid is pretty restrictive in how and what we can pay for. It has to be federally recognized benefit. It has to be something the state has implemented and has received an agreement from the feds for. Well, that's where these alternative payment models come in. Alternative payment models and the Medicaid managed care model is created to was implemented in Texas really to provide greater flexibility so that we could innovate, so that we're not just paying, okay, I'm going to pay this doctor for this amount for this code, and I'm going to pay this entity this amount for this code. It's moving into, I'm going to pay you a bundled rate, and within that, you're going to provide X, Y, and Z. And some of those may not be necessarily Medicaid covered benefits today, but comprehensively, they improve the health of the member. And so, if you're able to improve the health outcomes and reduce costs and improve member satisfaction, then I'm going to pay you bonus payments. And so it helps move the needle in multiple ways. Medicaid always historically has had low rates. And so allowing providers and other entities to come in and work together allows us to pay them for what they're providing and not just, the low state rates. It's giving them additional funds to be able to be innovative and do more things. But then the health plans in the state see it pay out through improved health outcomes and reduced costs long term. So I think that's the biggest thing we've learned is that we have been siloed, providers, community-based organizations, the health plans. And when we come together, we identify and come up with really innovative ways to improve healthcare or, the delivery of healthcare. And then we also identify some of the barriers that need to be addressed either legislatively or through the agency. And so I think that's why it's been great that the agency, Health and Human Service Commission, has been at the table during these learning collaboratives because they hear where the barriers are or where the admin burden is or where a policy needs to be changed. And we've made a lot of progress in getting better clarification or better guidance from the agency on how we can accomplish some of these goals working together.
And you definitely touched on it as you were describing all of your work, but I would love to hear in your own words how you would really describe or define primary care.
Yeah, I mean, it's kind of a saying that we've used in Texas for many years and when we moved to the Medicaid managed care model, but it's the right care at the right time at the right place to just ensure we have healthier Texans. So, ensuring that I'm getting that annual visit when I should be, I'm getting my Texas Health Steps visit to identify, what may be additional services that are needed, but doing it in a way that we're doing it at the right time, the right place, and it's comprehensive so that we're not just seeking healthcare through emergency rooms or when a chronic condition has become chronic or a condition that could have been managed becomes chronic. So really, I know that's a term we've used in Texas for a long time, but I really truly believe in it. That phrase, the right care at the right time at the right place to ensure that comprehensively the individual is healthy and that we have a healthier Texas in general.
Yeah,
And then
and oh, sorry.
I'll
No,
go
go.
ahead. I'm just saying.
No, no.
I was gonna
I love to hear you talk.
I was going to say, going a little bit beyond that, I think one of the things that we've struggled with here in Texas, but it's been something we've talked about is the health home, right? That the health home. So how can we take it beyond just the right place, the right time, the right um, type of care, but ensuring ongoing care through a health home, a provider that knows me well and understands what my needs are and can help coordinate my care. We've all struggled with this. I don't necessarily face some of the chronic conditions or some of the health issues that other individuals face, but having a provider that when I do have an issue come up, be able to know who I am and how I can, how I can benefit from certain treatments or certain referrals or, some of that additional care outside of just your annual visits or whatever, and making sure we're getting that primary care. So I feel like, if we could be more successful in moving into a health home, in the state, I think it would go a long way of improving the primary care and the whole experience of individuals.
Yeah, and I really appreciate you saying that because that's definitely a conversation we've been having over here at the consortium is, the clinician patient relationship really should be built on a relationship of trust, which, is really built over a course of time, right? It doesn't just happen through one visit. So having a consistent relationship with your primary care clinician is definitely, very, very vital for, advanced prime or high quality primary care. And curious on, like a challenge that you've been working to alleviate through your work, whether that could maybe benefit the primary care system or maybe it's what could primary care do, what could really change within the primary care system that could, maybe better integrate within non-medical drivers of health, or, kind of better advance, obviously, like the patient's life as well.
I feel like, just, very specifically working in the Medicaid world, what we've heard and what we've seen is access to that primary care and knowing how to locate and find a high quality primary care access point. So I would say through, one of the goals of the community health workers and the doulas bill that we're trying to implement is ensuring that those high risk or not even just the high risk, but pregnant women in the Medicaid program has somebody that they trust that can help them navigate the system and know where to go or how to find, primary care and what primary care visits should I be going to, right? It's a lot. So, when should I be getting this test and this screening and when should I be accessing this service? And so having someone help navigate that, I feel through community health workers and doulas, implementation of that bill will help with that navigation. I also feel like access, especially when you get into the Medicaid world, becomes an issue. We have throughout Texas, what I can't even remember the number is, it was very high. The number of counties and areas in the state that are designated as medically underserved, or where we have provider shortages, where we don't have pediatric specialists, or we don't have behavioral health specialists, we don't have primary care providers, and especially when you get into those areas of the state where access is an issue, you add in Medicaid and it's compounded, right? So if you have an access to care issue just because there's providers not available, those providers are having to take on the full community. Medicaid may not be the entity that they want to serve given the low rates, and the lower rates that they may receive. So I think one of the things that we're trying to do through alternative payment models is increase access. So being able to provide additional payment to a provider who can help a member access the right care, the right time, the right place, and let them know, hey, you need to come in for your postpartum visit. This is the date, and getting paid a bonus for encouraging those women to come in. Or, we've seen our immunization rates and our Texas Health Steps rates for the timely checkups for children as they're growing. We see our rates are pretty low in Texas. So using alternative payment models to incentivize those providers and those in different entities and organizations to be a part of the solution and encourage the people that they're serving to come in at the right time, at the right place, and get the right care, and being rewarded by the system for increasing that access and increasing the quality of care. So I would say a lot of the work I'm doing is trying to address the access issues that we face in the Medicaid world.
Yeah, and this is similar actually to what you just answered, but curious on what is that one thing. So really the question is actually if you had a magic wand, what is one thing you would change about the primary care system? It could be like, well, or workforce, like shortage of workforce, which you just cited, right? That we have counties without certain clinicians or access to clinicians. And so, or if it's really even what kind of barriers do you see that would be great if that one thing happened that could advance, again, the alternative payment models?
I think it kind of feeds into a little bit of what we talked about with what we're trying to do with the learning collaborative is if we had better coordination and better data sharing between payers and primary care providers, we could ensure better interventions. A lot of times the payers are relying on claims from providers that can come in months after a member, tested positive for a mental health need or tested positive as being pregnant. So the health plan is finding out a lot of times after a too late for a timely intervention. And so, and even when you get to the non-medical drivers of health, if there's an entity, a community-based organization, or a primary care provider that may be identifying a housing insecurity or a food insecurity, the health plan or the payer may be finding out after it's too late to have an intervention. And so I think really the one thing that I would do to improve access and improve the quality of care and improve primary care is better coordination and better data sharing between the payers and the providers. And then it's vice versa. I know it's kind of talking from the payer perspective, but also for the primary care physician to know what that member, that individual may have been accessing in the last 6 months. And so I think the better data sharing so that me as a PCP or me as a payer knows what's happening with that individual that we're both responsible for ensuring access to care to, better understanding what each are doing and coordinating a little bit better is just going to have exponential returns, I would think, on investments and improvement in primary care. Knowing a health plan, knowing that I arranged for medical transportation for a member, but then they still didn't show up to that primary care visit. And the primary care provider's office may have made the call to find out what the barrier was, but the payer may not know. And then the payer is going to be dinged for not meeting their quality metrics. And the primary care providers are struggling as well to know when and what and how to coordinate that care, and they're busy. So being able to share data, I think, would go a long way in the entire world of primary care. And I like to talk, so I can't just nail it down to one. So I want to nail down, kind of drill into the Medicaid world. One of the areas where I think we could improve primary care in the Medicaid world is improving the benefit package around dental care for Medicaid members, adults especially. So there's a very limited, if no benefits around dental care for adults in the Medicaid population in Texas, which is resulting in other chronic conditions and emergency room visits and even the need to have more interaction with the healthcare system because they didn't get that preventative dental care and now they have a more chronic complex issue that's going to have to be addressed. That's going to be more expensive, it's going to be more work for everyone involved, and it's going to result in a bad experience for that individual as they're going through the healthcare world. So I feel like better coordination across the board, but then in Medicaid, if we could maybe look at providing some more preventive dental care, it's going to help the entire primary preventative care and the quality of care that Medicaid members are getting.
Thank you, Laurie. This has been so informative. I wish I could just like give you the reins and you could just, fix the whole health system in Texas because I love everything that you're doing and I love all of your insights and ideas and yeah, just excited to kind of keep learning more from you. Which people, our listeners will be able to they'll be able to reach out to you directly so that they could ask you some questions and of course connect with you more on this. But again, really, really appreciate your time today and just excited for everything that's happening in Texas.
Thank you. I appreciate the opportunity. And yeah, I think we have a lot of opportunities in front of us that if we work together, we can continue to improve the care that Texans receive.
Thank you, everybody, for tuning in today. I really enjoy learning more about Laurie and her work, and we hope that you have too. You, of course, have the opportunity to connect with her, ask her more questions. If you have any part of your work that you want to share with her, please definitely do so and reach out to her. And of course, reach out to us too. If you had feedback on these episodes, on our guests, we really love recommendations. We are constantly learning more about what's happening within Texas, within our healthcare system. And we just want to make sure that we're tearing down any silos that we may have and really increasing our knowledge base. So thank you so much for tuning in today. This has been Texas Primary Care Consortium's monthly Monday Primary Care Talks.